Good afternoon, everybody. We're going to go ahead and get started. My name is Barbara Leach, and I'm with the Family Support Program here at the School of Social Work. And on behalf of Tamara Norris, our director, and myself, we'd like to welcome you to today's seminar presentation. First, housekeeping rules. We've got bathrooms are located by the elevators, ladies' room to the right, men's to the left. No food or drink is allowed in the auditorium. And in your packets today, you have a copy of the PowerPoint presentations, and there's an evaluation form that we strongly encourage you to complete. We use our evaluations to help direct programming and get feedback from you about what topics are of interest and helpful to you. So it is a pleasure to introduce our presenters today, Mary Hooper and Sean Schreiber. Mary and Sean will be talking about the changing landscape of North Carolina's mental health system, accessing services, and everything you wanted to know about LME, MCOs, but were afraid to ask or didn't understand. No pressure, no pressure. So, Mary Hooper is the executive director of the North Carolina Council of Community Programs. She joined the council in 2003, serving as director of policy implementation and provider relations, and became the executive director in 2013. Mary received her MSW from Florida State University and is trained as a child and family therapist. She spent a number of years conducting both clinical and administrative activities in clinical settings that included a children's psychiatric hospital and residential treatment programs in New England prior to moving to North Carolina in the 90s. Prior to her work with the North Carolina Council of Community Programs, Mary worked as a clinician at UNC's Center for Development and Learning, otherwise known as CDL, as Director of Child and Youth Services at Orange Person Chatham Area Mental Health Program, and as a mental health administrator at the Duke UNC Center for Child and Family Health. As the executive director of the Council of Community Programs, Mary's goal is to support member LME MCOs in their roles as public behavioral health managed care organizations. To achieve this, the Council is working to strengthen the MHIDD-SAS system statewide through improved collaboration with key stakeholders that include provider and consumer organizations, while continuing to work closely with the state's Department of Health and Human Services leadership to address key policy issues. Don Schreiber has served as the Chief Clinical Officer for Alliance Behavioral Healthcare since its inception in July of 2012. In this role, he is responsible for the oversight and administration of the clinical operations departments within Alliance, including the Access and Information Center, Utilization Management, Care Coordination, and Appeals. Prior to Alliance, Sean was the Director of Clinical Operations at the Durham Center, an LME that was one of the predecessor organizations to Alliance Behavioral Health. Sean is a North Carolina licensed professional counselor with over 20 years of experience developing, administering, and managing behavioral health care services in both community and inpatient settings. Before joining the public sector, Sean, as Director of Development for a multi-state provider organization, helped to expand and operate publicly funded community behavioral health services for both adults and children. and authored numerous successful responses to RFPs aimed at expanding evidence-based service access for at-youth risks. With no further ado, I give you Mary Hooper and Sean Schreiber.
After an introduction that long, I feel like you're probably ready to go home already, but that's okay. Thank you, Barbara. As Barbara said, I'm Mary Hooper. I'm the Executive Director of the NC Council of Community Programs. And to be perfectly honest, I feel like I'm the warm-up act here today. The original request that came from Barbara and the folks here was to provide you with some very specific information about accessing services for consumers in North Carolina. To be able to do that, you need to hear specifically from someone who is involved on a day-to-day basis with one of the LME MCOs, and Sean, as Chief Clinical Officer at Alliance, is certainly one of those folks. My job is a little different. As the Executive Director of the North Carolina Council of Community Programs, my job is to do whatever it takes to support and enhance the work of the LME MCOs across the state. So my level of detail in terms of how do you get from point A to point B internally to an LME MCO is probably not at the level that you deserve to hear. But in order to really understand this system, I think it is important to go through some general information about our LME MCO system across the state, and that's what I'm going to do today. So bear with me, and then we'll get to the good stuff with Sean. How many people in this room actually know what an LME MCO is? It's okay if you don't. Okay. Many folks worked for one of the LME MCOs? Bless your heart. Not anymore. Okay. That helps me. Thank you. And before I get started, I need to identify my bias. I have a very strong bias, and there are a couple of people in this room that I've worked with for a number of years. I very much believe that public dollars should be managed publicly. And so the LME MCOs, as public managers of public dollars, fit very much into the work and the philosophy that I have. This is not to say that non-public entities like commercial managed care organizations, and we'll talk about those, I'm not saying that they're the sum total of evil in the world or that they're even bad, but I am saying that not unlike those of you who are students here at a public institution, there is value in utilizing and accessing public resources. And you know, actually, I was just told, I haven't seen this research, but there's some research for those of you who are students that suggests that at the master's and higher level of education, the outcomes with public institutions are better than with private ones. So congratulations for being here. Okay. The Council of Community Programs, which is the organization that I'm the director of, is a nonprofit organization. It's been around since 1983. Our responsibility is to work with the mental health, IDD, and substance abuse authorities to improve services and management. We are a statewide voice for our members. We focus very much on policy development and analysis, some publications, technical assistance, and training and education, not just with LME MCOs, but also with providers, consumers, and other stakeholders across the state. We facilitate a number of forums and work groups, some of which are internal to the council, some of which are actually requested by folks at the state level, many of which are collaborative with provider organizations these days. And we try to work very collaborative with key stakeholders and provider organizations. It's hard to hear. Better? It's hard for me to stay still is the problem. I'm really sorry. We'll try to keep moving it. I think I'm just going to pay better attention to this. I'll do it. Thank you. This is a shameless plug for the council, and it's the only commercial that I'm going to do today. In addition to the work that I've described, the NC Council of Community Programs hosts 2 conferences a year. One is our Spring Policy Forum, which is usually in June. The other is our Pinehurst Conference in December. The Pinehurst Conference, and I'm always amazed by this, and I can't tell you how grateful I am, tends to be about the biggest and most well-attended gathering of folks related to mental health, IDD, and substance use disorders in the state, both at the practitioner level, the policymaker level, administrators, and it's at Pinehurst, which, as a lot of you know, is a pretty nice place to hang out at for a few days. Our conference brochures for our conference this year is December 2nd to 4th. I've brought some brochures if anyone's interested in taking a look at the information and at some of the offerings that we have, and we'd be happy for it. If you have any questions, you can feel free to let us know about those. That's the plug, and that's over. So today we have these things called LME-MCOs, and that stands for Local Management Entity Managed Care Organization. That's not where these people started with these organizations. Back in the 90s, there were, by statute and rule in this state, area program authorities, what we used to call mental health centers. There were 41 of them. One of them was actually just about maybe a mile down the road, and it was called OPC Mental Health Center, and that was one of the places that I worked at early in my career in North Carolina. And as I said, there were 41 area authorities across the state. If you think about that, there are 100 counties in North Carolina. So that kind of gives you an idea of how expansive roughly each of those area authorities were. I mean, they usually had 2, 3, maybe one county if it was an urban county or a large county. And they perked along and they provided services. And when I worked at OPC, we had the child section, we had adult, we had substance abuse, we had the William program, we had all kinds of, we had it wasn't IDD in those days, it was DD. And we provided services. And frankly, we thought we did a pretty good job. Just because you think you do a good job doesn't mean everybody else does, though. So in the early 2000s, the General Assembly saw fit to pass what was called mental health reform legislation. And in that legislation, the directive was that these area programs were required to divest of all services. So they could no longer be service providers. They had to move along and divest their services and contract with provider organizations, which became a boon in some ways to provider organizations. The thinking behind that, for the most part, was that area programs did not give consumers enough choice of service providers. Because it was an area program, you showed up at the mental health center. If you needed outpatient therapy, you got it. If you needed some kind of therapeutic foster care, we probably had that program. But those services were self-contained within the area program. And so the belief was that consumers needed more choice and that the area programs as such couldn't provide that. There was also this sort of underlying additional piece of concern that maybe those area programs were not necessarily managing the money as well as they should. This is my bias. The not managing the money as well as they should really had a little bit more to do with the fact that when you have limited resources and gigantic needs, there were times, no question about it, where there might be a little bit of money left over in this pot and somebody would move it over into this pot because we had more service needs over on this side. So there was a little bit of flexibility, and you're nodding, you remember that. I will say that I don't know anybody who went to the Bahamas on a trip using any of that money. It was more a matter, but anyway, so that's what the General Assembly said we needed to do, and that's what happened. And through that process, the number of area programs decreased from 41 to 39. In 2005, Piedmont Behavioral Health, which covers at that time, the Charlotte area, got this idea that they could put together a waiver. And for those of you who know anything about waivers, you know that to get a Medicaid waiver, you have to make an application to the Centers for Medicaid Services, and it's a pretty lengthy process. PBH did that as a demonstration project, requested and were approved to be a waiver. And so they started the first real Medicaid waiver program in North Carolina. There had been an attempt at a 1915B waiver back in the 90s in North Carolina through this effort called Carolina Alternatives, and it was through Children's Services, but that did not last too long. So PBH gets going on this Medicaid waiver, which requires an agreement with CMS that you will provide with a certain amount of money the services necessary for a Medicaid population within your catchment area. It was a demonstration project. They did very well. They showed some real positive progress for services. And it became clear, not just in North Carolina, but federally, there is a process now occurring that would clearly point in the direction of managed care. Am I still not doing a good job? Then, one second. Can you hear me now? How about now? Now? It's not on. Is it on? I can fake it. It's okay. I'll try to stand here. How's that? Because unless I put it in my mouth, I can't get it any closer. That's good. Thank you, Barbara. Okay. Okay. In 2006, there was some additional legislation that redefined area programs as local management entities across the state. And then in 2011, and this was the big switch, local management entity and managed care organizations came into sort of being. And through this process, as you can see, we went from 41 area programs, area authorities, to 39, to 31, to 24 LME MCOs. And at the point of full waiver implementation in 2013, we landed with 11 LME MCOs. There's a reason why they're called LME MCOs. Some folks have said to us, well, now that they're doing managed care, why are they still called local management entities? There are two parts to managing public dollars. One is management of state dollars. The other is management of federal dollars or Medicaid dollars. The LME side, the local management entity, is responsible. Those responsibilities relate to the management of the state dollars. It is the agency that plans, develops, implements, and monitors services, obviously in a specified geographic area, according to the requirements of the Division of Mental Health, DD, SAS. And the Division of Mental Health, IDD, SAS is the side of the state system that is responsible for state dollars. And as part of that, the LME MCOs are required to develop a range of services to provide both inpatient, outpatient treatment services and supports for both uninsured and underinsured, that's a typo, individuals. I will say, in terms of state dollars, and you'll hear this over and over again, two things. The number of state dollars that an LME MCO has available to it is a limited number of dollars. So the pot is limited. The other thing is, state dollars, state services are not considered to be an entitlement. Medicaid services have certain entitlements that go with them. State dollars do not. So from the perspective of a consumer, if I am running an LME MCO and I have used all of my state dollars, that's it. And that sounds pretty harsh, and it can be very harsh. And this we'll come back to this in a few minutes when we talk about what's happening right now. But anyway, state dollars are not an entitlement. The MCO side, MCO is an umbrella term for a Medicaid health plan that provides behavioral health care for a predetermined monthly fee, meaning there's a capitation, and coordinates care through a defined network, a closed network of providers, physicians, and hospitals. Today, as opposed to about 3 months from now, today we have 8 LME MCOs, and that has changed. I mean, as recently as last week, there's been an announcement that's changing that. Currently, the 8 LME MCOs are Alliance, Cardinal Innovations, Centerpoint, East Point, Partners, Sandhills, Smoky, and Trillium Health Resources. And those groups now, those 8, cover the 100 counties that previously, back in the day, were covered, by about 41. There was an announcement last week for anyone who happened to be reading the newspapers, letting us know that Centerpoint Human Services has an intention to merge with Cardinal Innovations. So that will bring us down to 7 LME MCOs covering the whole state. If you read the papers, for the last couple of years, there has been a hope, expectation, intention from our Department of Health and Human Services collaborators that the number of LME MCOs in the state be reduced to a total of not more than, the term was 3-ish. So 3 to 4 LME, so 3-ish. It's very, like everything else, it's very clear for us. Again, same geography, same individuals that need coverage. You can imagine what that means in terms of size and breadth and expansion. This is the map as it stands today that sort of put this in there just so you could see sort of how the state plays out. Way over in the east, we now have this Trillium in yellow. Sean, who is with Alliance, is sort of that nice pale green in sort of the central eastern region. And it goes on. Centerpoint is the yellow up in the top that will eventually become the purple of Cardinal. So you can see what the territory is of some of these places. I mean, if you think about it though, and you look at, as an example, Alliance's area looks like 1, 2, 3, 4 counties. Then you look way over to the east at Trillium, and I think they have, I don't know how many counties, 24, 21, something like that. Sean probably has a much higher population than Trillium. If you look at some of the counties that Trillium covers, are very sparsely populated. That has important implications for services and provisions and for provider organizations. But that's our map. The core functions of the LME MCOs, and these are by law and statute, to provide access, screening, triage, and referral, network development and management. As we said, in the LME MCO world, the network is a closed network. And so LME MCOs are responsible to ensure that they have sufficient types and numbers of providers relative to the need in their local communities. Every LME MCO is required to conduct a gaps analysis. Sometimes it's annually, sometimes it's every 3 years. And they use those gaps analyses not just as paper that goes on a shelf, but to figure out what are the services that they are providing, what's sufficient, where are some of the holes in services that they need to look at, and then how to use their the dollars accordingly. Utilization management is huge. If you are working in the system today, you have a Medicaid consumer and you want outpatient treatment, or you want intensive in-home, or you want some other form of treatment, you now have to approach your local LME MCO and request an authorization, no different than I have to do or my provider does for my treatment. Care coordination and quality management, very important for these folks, as are community collaboration and obviously the financial management. Speaking from the perspective of the council, the community collaboration becomes one of the most important things that we do, not just for the LME MCOs, but I think in terms of benefit to consumers. What we have finally realized, and it's taken everybody, not just the LME MCOs, but providers, stakeholders, and other folks, a little while to really understand, is that the success of a provider organization, the success of an LME MCO, meaning successful treatment for clients and availability of treatment, the relationships between the LME MCOs and organizations have got to be pretty symbiotic in a lot of ways. There's a firewall, and the firewall is he's the payer and I'm the biller. So we have to have a firewall because that's an important piece. But if Sean and if I as the provider and Sean as the authorizer are not talking pretty frequently about what's going on, what the needs are, and how we do it, The consumers over here are going to not get what they need. And that's the thing we have to ensure does not happen. This is a statistic just to give you a general idea, and these were the numbers. These came out of the state. These weren't my numbers in June. According to our DMA folks, there are almost 1.5 covered lives for Medicaid individuals in the state. And on the average, 94,000 of those folks are being served on the behavioral health care side on a monthly basis. It's a lot of people. In terms of the underinsured, these are the state services. This has come out of DMH. Fairly close, similar number of covered lives. 25,000 of those individuals are served monthly. So that's still a good chunk, but you see the difference. And then you get down to the budgets. And I will say, based on recent legislative activity, that there's been an awful lot of attention to Medicaid and what's happening with Medicaid and Medicaid transformation. People need to understand that there are things happening on the state dollar side also, and they have a huge impact on consumers. So the budget, the total state and Medicaid budget, the total budget is $3.3 billion, and that's what the LME MCOs are responsible for. The Medicaid side of that is $3 billion. The state side is $298 million. Huge difference. So you can imagine what that means in terms of potential services. Did you have a question? No? I'm sorry. You mean for administration? I think the administration is not over 7 to 8% at this point for each of the LME MCOs. So if you compare, well, it's hard to compare our public LME MCOs with commercial managed care organizations in terms of the administrative piece, but generally we're told that most commercial managed cares run about 15% admin. The other difference is, and this to me was astounding, we can go back. My understanding now is that things like care coordination in commercial managed care counts as under service dollars. For our LME MCOs, care coordination is considered part of admin. So if you think about what that means, it tells you that of that, whatever the percentage of admin is and service dollars, there's still a higher percentage of service dollars, I think, going directly to consumers in the public system. And thank you, Neil, for nodding your head. It makes me think I was right about some of this. So there's your statistic. These next two slides are much too information dense. I just wanted to give you an opportunity to see what services exist out in North Carolina under the Medicaid and state funds. So we just pulled together a couple of slides. You have this in your packet. These are the services that are covered by state funds. Again, state services are not an entitlement. So it doesn't mean that I can go into any LME MCO and be guaranteed that I will get these services. LME MCOs, however, are required to ensure that they have these services. It's not that they have the money to always provide them. These are Medicaid covered services. Medicaid is the entitlement. The one thing about the entitlement that you have to know, however, is that yes, this is part of an entitlement. Most of the services on this list are considered optional services. So if you go to another state and you look at what their Medicaid covered services are, maybe 2/3 of these, maybe half of these. The required services under the entitlement are outpatient, emergency, and inpatient. So if you happen to be working in intensive in-home, that's not an entitlement service. It's not a required service. Go ahead. Well, EPSDT can enhance some of that. That's right, for kids. But in terms of it's that sort of fuzzy area. But again, if you go to another state, you may not see the same array of services that we have here. And you're right, it's better for kids. It's not good for adults. And just to give you an idea of some of the work that our LME MCOs are doing, Call centers are the place where everything starts. This slide just gives you an idea of the total number of calls that any one of our LME MCOs gets in a given month. And you can see that the numbers are impressive and they're high. Equally impressive to the volume is that, for example, the average speed of answering calls is somewhere between 3 and 8 seconds. I don't know when the last time was that you called United Health, Blue Cross Blue Shield, or that I called my provider. If I can get off Muzak in less than 30 seconds, I feel like I've had a really good day. The state demands a lot of the LME MCOs in terms of following through with certain requirements and certain parameters. And while we feel very strongly that we need to have a much better system where outcomes are based on consumer lives, consumer satisfaction, there are statistics here that sort of indicate to you that these guys are doing what they are doing their best to do what they're expected to do. Occasionally in the paper, I've read that there are no standards that the LME MCOs are held to, and they're just off spending money willy-nilly, and they're sitting on pots of money and all this other stuff. So every month there is a report, which means LME MCOs have to submit 30 reports a month. I don't even know how many now. 74 reports a month to the state. And the state culls that information and puts out information about what the performance measures are for each of the LME MCOs. DMA has performance measures, DMH has performance measures, and they have their standards and they divide each of the LME MCOs accordingly. The interesting thing, just to show you how tight these measures are, on this slide, you see that little yellow N over there, which means that ECBH, which is now called Trillium, but as of June, they were still East Carolina. They had not resolved 90% of their complaints, consumer complaints, in 30 days. Well, that's unfortunate. You want complaints to be resolved. If you read down below, however, what you see is that ECBH had 3 complaints during that month. One of them was not resolved in 30 days, and therefore, they were put in the category of, this is not good, and if you do it again, we're going to take away your ability to be an LME MCO. Those are pretty rigid rules. Did anybody here not follow the legislative session that just ended at 4 o'clock in the morning last week? One of the reasons that the session did not end in a timely fashion had to do with the fact that some members of the legislature, particularly on the Senate side, had made a decision that Medicaid transformation had to happen. You have heard probably from the governor's office on down that Medicaid is broken. If I heard one more time that Medicaid was broken, I was ready to break my own neck, quite frankly. Medicaid is broken means costs are out of control. We are not able to provide services, litany of things. I am here to tell you that Medicaid on the behavioral health care side has not been out of control, cannot be out of control, because we have a capitated system, because our LME MCOs are given a specific amount of money to do what they need to do for services. So on the primary health care side, basically when they say Medicaid's out of control, what they're saying is we need to find a way to bring in some kind of waiver activity similar to what we're doing on the behavioral health care side so that we have a capitated system. And the General Assembly was very clear that they wanted this to happen this year, and there was a lot of debate, a lot of challenging internal to the legislature. But in the end, the Senate side prevailed to the extent that there is now a plan that will go forward that will bring full managed care into all parts of Medicaid and health choice in the state of North Carolina. It's not an easy thing to switch from what we call a fee-for-service model to this managed care activity. And so as the primary healthcare side of the house is moving in that direction, our council and our LME MCOs spent a lot of time and energy encouraging the legislature not to do anything to impact what's happening on the behavioral healthcare side while this primary healthcare side is getting its legs. It's going to take 3, 4, 5, 6 years for this to happen. We're not opposed to it, but we are saying give them time to get there before you start changing our stuff. And mine just switched to a picture of the old well. So this transformation that's occurring will make several major changes to the Medicaid system in North Carolina. There was a great deal of discussion about taking the Division of Medical Assistance, which is DMA, taking that out and creating an entirely different department. Initially, that was going to be a department that would be separate and apart from anything in DHHS, which would have been really confusing for a lot of us. But as it stands now, there will be a Division of Health Benefits, which will manage Medicaid. They will have a different relationship to the state. Folks who work for DHB will have different job requirements, and that will hopefully, according to the legislature, allow them to bring in folks with expertise in certain areas. In addition to that, and this is the other really big piece, the legislature has directed the state through this DHB to submit waivers to CMS, state plan amendments to CMS on or before June 1st, in which the state of North Carolina is requesting the opportunity to open up, for a 1915 waiver or some kind of waiver for primary health care that will result in an opportunity for both commercial managed care organizations and homegrown provider-led entities to submit RFPs to provide services. There will be 3 large commercial managed care organizations that will provide services on the primary health care side to the entire state. So if I'm a Medicaid consumer, I will have 3 large entities that I can choose from among. Or there will be potentially up to 10 provider-led entities, and they're kind of not really well defined, but they are more homegrown, maybe hospital groups, maybe groups of physicians, who will also have the opportunity to work as smaller managed care organizations. I honestly can't figure out how this is all going to work. I'm just being honest at this point. It's still very unclear, and there are not a lot of details. My concern is that there will be a lot of confusion for consumers for a period of time. Under this new system, LME MCOs are allowed to continue as they are for a period of about 4 years if you sort of crunch the numbers based on when the contracts will be let and other things will happen. There is another group called Community Care of North Carolina that has been very involved in this state with care coordination on the primary health care side, and they will be phased out is our understanding. And there will be more legislative oversight committees established to ensure that this process moves forward. In the budget this year, there were some good things. There were some increased dollars for community hospital beds. TBI funding got some money, and a waiver for TBI, great thing. On the single stream side, which is the state dollars, we have taken a massive hit for the LME MCOs. This current fiscal year, $110 million will be taken, well, $110 million will be withheld from single stream funds from the LME MCOs. And the LME MCOs are expected to supplant those dollars with any savings that they have accrued over the past few years. And in the second year, because our budget is a biennium budget, in the second year, there's an additional $152 million that will be taken from the LME MCOs or withheld that the LME MCOs are expected to supplant with their own savings. I can tell you that it isn't going to work real well. We have worked really hard with the LME MCOs, and they're going to find a way to take this first cut. They're also required in this budget and by the legislature not to decrease services. It is written. That will work this year. They're going to find a way to do it. In the second year of the biennium, it's not going to work. Good.
On a previous slide, you had the amount that the state contributes. Is this 110? Isn't that about a third of what the state contributes, or am I misremembering?
No.
Okay.
We walk around now saying do the math, because 298 million, and if you add those dollars up, you're right about there. The way that the state budget, and I am not an expert in this, the way the state budget is constructed, because it's a biennium, first year of the biennium, which we're in, is 110 million. Second year of the biennium, 152. Okay. Then we go into the next legislative session and the next budget. So, we're kind of saying to the legislature, okay, so you take this for 2 years, after which there's nothing left to supplant these dollars, which means you got to put that money back into the budget. Well, they're not real worried about that right now.
Mary, it's me, I'm echoing. She gave me a microphone. That was dangerous.
It's okay.
I just have to say that, with the state funding, one of the biggest problems we have now is the fact that we do not have enough residential supports. I'm with Wake County Wake County Adult Guardianship, and we have so many folks that just do not have appropriate housing.
Yep.
And the funding for the appropriate housing comes from the state dollars. That's where your residential supports come from. So we're just going further down the hill with that. And what's the most important thing that you can have? It's your residential supports. You can't
roof over your head.
Yeah, you can't squat if you don't. It's just, it's disgusting.
These budget changes are going to have on, like, the innovations waiver, and what cutting the state funds even more so is going to have on these people that are on the innovations waiver wait list?
I can't with really good authority other than to tell you it's not real good. There are these formulas about things called maintenance of effort that go to some of the services that DD folks in particular access, because you have folks who are on the waiver and then you have folks who are not on the waiver. Again, for folks who are not on the waiver, the implications are pretty dire. I'm not here to paint a picture of doom and gloom, but I think it's really important that people understand that what we have got to do, what folks like I have to do, is advocate really, really hard that 152 million gets reconsidered. I feel like I don't feel like we lost a battle this year. I feel like we lost a war, to be honest. But we got another big one coming here. Those dollars are not about the LME MCOs. It's not because this guy needs a job or I hope that I have a membership to sustain me. It's about consumers getting the services they need. This is not a perfect system. The LME MCOs have plenty of warts and bumps and have done some things that we wish they had done differently. But I will tell you, you start stripping that out, nothing good is going to come of that.
Regarding the cuts and everything.
Yep.
And it was my understanding from reading that the cuts were coming from money that were in reserve, and that this is money that the LMEs had as a result of the savings that they had saved.
Right. If God help you if any of you spent time at the legislature listening to some of these conversations like some of us did. But if you were there, you heard statements. These are statements that were made in these big legislative meetings. The one that I had the most heartburn about was when they said that the LME MCOs were sitting on $700 million, that money was laying around. Okay, that's one thing to say. A couple of things about that, and I'm going to try to wind up so that Sean can get up here and tell you the really good stuff. First of all, you saw the numbers that the LME MCOs are managing in terms of dollars. there's a certain percentage of money that any business has to withhold, and so that they have like 60 days worth of operating capital. In some cases, these LME MCOs are big businesses. In some cases, it's $60 million. That sounds like a huge amount of money, and it is, but that's what it's going to take to cover services, to cover payments to providers in the event that the state isn't able to pay the LME MCO so that they can pay the provider. And that has happened, and we have been able to continue to pay providers. They have been able, they do, most of the LME MCOs have some savings that, to use a bad term, would be somewhat unrestricted, that mostly are left over from the days when they were LMEs and before they became managed care organizations. Some of them have held on to that money. They've done some planning, but according to what we showed you in the beginning, some of these LME MCOs have only been LME MCOs for 2 years. So, good business people are saying we got to get our feet on the ground so that we can start really reinvesting and know that we have a good foundation. Some of them have been able to do that because they've been around a little longer than others. Others are just starting. So yeah, they do have some savings. Not unlike a commercial managed care organization that would have some savings that, number one, you probably wouldn't know about, and number two, would be going back to stakeholders and shareholders. The LME MCOs are required, particularly with their Medicaid savings, to reinvest in services. And so the dollars that come in are going to go somewhere. They're going to stay in the state, and we're going to use them. There have also been questions recently about everything from transparency to salaries. I'm very comfortable putting our LME MCOs up against, so to speak, commercial managed care. Again, I don't think that commercial managed care is inherently bad, but I do think that public dollars should be managed publicly, and I think you get more transparency and you have more opportunities for more input in a public setting. And I'll die on the sword on that one. So, I was not able to give you as much detail as I would like to have. You have more information in your packets. I'm going to stick around after Sean talks. I'm happy to talk some more if people would like to. We also have a directory, a council directory that if anybody's interested in, you can get your hands on. Gives you some information about names, numbers, everything that you need to know about LME MCOs. That's what I got. Thank you.
Thank you, Mary. Thank you for the opportunity to be out today and give maybe a ground level view of some of the functions of one of the local MCOs. I probably can't be as candid as Mary, as basically I'm employed and get paid by the state right now, so my comments will be less editorialized. And also just to be clear that all of us are a little bit different. I think we share some common functions, and hopefully we do things fairly similarly and have a mission to serve the public, but I am just speaking really more from the Alliance perspective. Let me just start by giving a bit of an overview of our philosophy, because I think we've transitioned. A couple years ago, we were the Durham Center, which 7 to 10 years earlier, they were a service provider. Community mental health, did some basic outpatient services, some case management, and in a 10-year period, evolved to become an LME, where they were really responsible for managing state-funded services within Durham County. So I think Durham County has, I'm not sure the population, 350,000 individuals living in the county, and they were managing a small budget to our formation in July of 2012, where we became responsible for a much bigger scope and merged. It's been a really interesting shift in practice. And the reason I mention that is you have a lot of people who work for Alliance now, who used to work in the public helping segment. And I think that is one of the things that maybe differentiates us between private managed care and public managed care. You have people who've mostly dedicated their careers to community and public service. The other thing that's a little different in Medicaid managed care than typical commercial managed care, when you're talking about Medicaid managed care, you're talking about population who's basically getting on insurance either because of economic status or because they're disabled, aged, blind. So really already you're much higher at your higher risk populations. So the approach to managing that is much different than traditional managed care. Traditional managed care, you have outpatient services and inpatient services. you have a basic benefit packet, and you authorize some of the more expensive services. You don't have to do a ton in between. For our population, we just know that doesn't work. You're dealing with all kinds of different social determinants of health. So from an MCO perspective, it's not just about managing state and federal dollars. You're really kind of helping to manage and shape an entire system. I think that's one of the things that makes us a little bit different. One of the things, I think there was a question earlier regarding the innovations waiver, and this is a good example of where I think we have a different role. So we have roughly in the Alliance area about 1,800 individuals who are on innovations. Let's say if we decide to take a standard traditional managed care approach and try to figure out how to save as much money per individual in that program. Well, if they're not able to sustain, as Medicaid, we're responsible then provide the next adequate level of care. So in that case, if we cut innovation services, which allow people who typically rise to an institutional level of need, if we cut those services, they go back into an institution, which is less expensive or more expensive. It's not good. It's really a step backwards. So the goal really should be for us to make sure we're providing whatever supports individuals need, and obviously within a reasonable framework so they can live in the community. But unlike in commercial managed care, in some services, you may cut a service too early, but there's really no other expensive alternative to go other than inpatient hospitalization, which is episodic and typically short term. So really for us, we have more tools, but there's also other risk if we just take a kind of slash approach to managing care. So just a little bit about Alliance. We are the managed care organization, LME, that's responsible for managing services in Durham, Wake, Cumberland, and Johnston counties. That gives us a population of about 200,000 plus Medicaid individuals and about 1.7 million individuals to serve. We are responsible to use our state dollars to provide behavioral health services. And when I talk about behavioral health services, I'm including substance abuse and services for individuals with intellectual and developmental disabilities. So we're responsible for any part of that 1.7 million who needs a crisis service, regardless of their ability to pay. So 24/7, we have to ensure there's some crisis services in our community, and then be able to provide service to anyone who's at 300% or under the federal poverty level. So it's a pretty big scope. And you'll see when I get to our funding slide, we get pretty big chunk of money for Medicaid and really small amount to manage basically a larger population, which you could argue have much more severe needs. People without access to health care in the past tend to come into a system in much poorer health. They've let their health care deteriorate. People have not addressed mental health issues, addiction for much longer. So you actually see sometimes a much more impaired population who are needing our state-funded services. So we operate under the 1915 BC waiver. In essence, that means we have two waivers we run concurrently. One provides state benefit plan services for individuals, so that includes things like outpatient counseling, inpatient services. If you've heard the term enhanced services, those are the more comprehensive community services for special populations. So you have assertive community treatment teams for individuals who are chronic and severe persistent mental illness, intensive in-home services, and a host of adolescent residential services that we provide under the B waiver. The C waiver is a separate waiver for individuals who have been deemed to be basically functionally eligible to reside in intermediate care facilities for individuals with developmental disabilities. So basically, it's a separate waiver for individuals who need institutional care. So of our total budget, a little bit over a third of our funding goes to that population. So where we have 200,000 individuals, we have to provide these Medicaid B waiver services for. We have roughly 1,800 individuals who use basically a third of our budget in services. So a fairly healthy portion goes to support the innovations waiver. Unfortunately, we still have a lot of institutional care that happens in our state, and you can certainly argue some people need that level of care, but we spend close to, I'm trying to think in total, we spend somewhere in the neighborhood of $54 to $60 million a year on institutional level care as well. So a large portion of our budget is really not really able to be all that well managed. So we're the other frustrating thing in our system, and I don't want to go into things that are bad because there's a lot good, but one of the issues, if we were able to improve the quality of care, maybe decrease some spending in our innovations waiver, it doesn't actually equate to us getting more slots. So the state has a slot allocation system, which I could not even begin to tell you how it works. But basically, if we save money one area, we're not able to reinvest that to move more people out of institutions. So that's one of the frustrating things. On the positive side, on a B waiver, if you do have savings, you can reinvest that in service, and you can incentivize services to help drive better care. So an example, I think, of a success of Alliance was when we started managing care, we had at any given time about 140, 150 children in locked psychiatric residential treatment, who many of those children have been there for a year, 18 months or longer. I think something like 25% were out of state. Some, not even just across the border, but several states away. So we made a concerted effort to move kids back to the community. Now, you could take the approach that you could just deny all those services, but that creates a whole cluster of issues and crisis, and it's bad for the consumer. So we're able to create some services, incentivize some rates, do some wraparound models using kind of our flexibility as a waiver site to do that. Today, the number is about 72 to 76 kids who typically at any given time are in these locked facilities, and the average length of stay is about 5 months. Now, for us, the goal is to make sure they don't go back and maintain their community tenure. Let's see. So I'm just going to briefly go over, here's what the operations, internal operations look like. Like anything, we're a big business. We have a fairly large amount of money we're responsible for. We have an administrative wing that oversees kind of the day-to-day operations. We have an access and information center that runs 24/7. That's really kind of the portal of entry for many individuals into our system, and I'll spend a little more time talking about that. We have a care coordination department, and I'll just discuss a little about care coordination later. I won't pretend that it's case management, but I do think it has a helpful function. And where possible, I know Alliance and several of the LMEs are trying to bend that definition as much as possible with some of our populations who need greater follow-up. We have a community relations section that's primarily responsible for really looking at the communities we work in. We are, working in a publicly funded system. We have probably 50% of the children in our care who receive residential services are in foster care. So we have to really have good, active relationships. We have to understand the needs of our stakeholders, and community relations helps bring that together and really look at the overall conditions in the community that might sustain people being more successful. We have a utilization care management department. Some of it performs a standard managed care function where we review requests for service and then also kind of actively oversee the care. Again, I'll go into some of these departments in more detail. On any given month, the utilization management department processes about 6,000 requests for treatment. We have our networks management, quality management. There's a lot of money at stake. There's people's care at stake, so we have to have a well-defined quality management department that really looks at data, looks at trends, makes sure we're in compliance with all kinds of federal statutes, and make sure we're using our money wisely. So the quality management aim of Alliance helps look at that. And then there's the whole external facing arm, which is looking at the provider network and making sure people get appropriate care. Business operations, we have to pay claims, pay employees, pay the bills, all those things. A big focus for us is corporate compliance. Again, that's one of those parts of the MCO that faces internally and externally. The first part is that we have to make sure that our staff are following all the rules and laws. We have to make sure that our staff are not inappropriately referring to their friends in the provider network. We have to make sure that when we authorize, we're being fair and equitable. We have to look for patterns. Believe it or not, they look through all of our staff's decisions and see if they can find patterns and authorizations that may look like they're giving favorable treatment to one provider over another. And then on the outside, it looks at fraud and abuse. Unfortunately, that is part of probably any healthcare system, and it's certainly part of the Medicaid system as well. So they do a lot around looking at billing patterns, use of services to detect patterns of misuse, and then take action. One of the things that's been surprising to me is just the amount of information technology it really has taken to do this work effectively. The systems just for processing thousands of authorizations, thousands of requests for service. I think we may, in a month, pay out something like 100,000 healthcare claims. So that's a huge part of our IT infrastructure. But probably more importantly, that provides us with tons of data to help us understand what's going on in our communities and be better stewards of public funding. So a lot of emphasis on there. and healthcare integration. One of the big moves and criticisms of the current system is it splits the people in two. So you have a physical health system, a behavioral health system, and they're not well integrated, and they need to be. What's been interesting, if you look at the trend of managed care across the nation, typically behavioral health is the last part of a segment under managed care that you actually look at bringing physical health care first. If you look at the budget, that's where, again, 2/3 of the money is, and then behavioral health kind of gets tucked in at the end. And what's really, there's almost a perverse incentive when you look at managing behavioral health first. If you look at kind of individuals who have the highest health care costs in our system, they're people who have co-occurring disorders. So things like diabetes, heart conditions, high blood pressure. And then they also have a concurrent mental illness, which makes them not address their physical health care very well or unable to address it very well. So if you start ratcheting down on behavioral health care first, you're almost starting to take away some of the foundation that would really help lower the physical health care side of Medicaid. So it's really good that the system's going to be more consolidated. It just seems like it was maybe done in a reverse order. So anyway, that's just a little bit about our operations. All right, so budget. So Mary shared with you a high-level view of our budget. Here's Alliance budget. We're a publicly funded agency, so we'll be transparent. For Medicaid to provide services, we received $357 million and a lot of change. That's to serve the needs of all 200,000 individuals who might need a Medicaid service. Typically, at any given time in our catchment area, we have about 8% of the population receiving some sort of behavioral health service. On the state side, we get about $50 million. And again, we serve roughly almost the same, we're responsible for the same number of individuals with that dollar disparity. Additionally, if you're familiar with Medicaid programs, Medicaid will pay for child residential services. Medicaid does not pay for any kind of adult housing or residential option. So Medicaid will pay for inpatient hospitalization for adults, and Medicaid will pay for crisis facility stays. On the innovation side, there are some residential supports we pay for. So in our state budget, which is much less, is where we have to also provide any supplement and support to individuals who cannot live independently in the community. So really, when we start thinking about our state budget, it's pretty minimal. A lot of it is really tied up to individuals who need residential supports. Alliance is very fortunate that we are a conglomerate of a bunch of single county programs that used to get decent amount of county funding. So we get a fair amount of support from our local communities. Without this, I think our picture would be a little bit bleaker. And our $36 million, roughly about a third of that goes to support crisis facilities, which we would not be able to have in the community without that. So it's a nice way that by braiding some of our funding, we're able to kind of decrease the use of certain state dollars for crisis and to impact some of our Medicaid spending on crisis, which gives us more money for community services. So that's our total budget. So one of the things about the MCOs is we have a responsibility to develop a network. And it was really interesting how this came about. So in the old days, any willing and qualified provider could enroll with DMA and provide a Medicaid service, and there was some varying degree of oversight. The state obviously didn't have kind of the infrastructure to really oversee a Medicaid network that expanded the entire state. They at one point brought in value options to do some utilization controls, but this still wasn't getting at cost and quality. So initially, when Alliance became a waiver site, and us along with all the other waivers, we had to accept every single provider in our network who was providing a billable service 6 months prior to our go live date. So what that meant for us is in a short time, we had to enroll roughly 2,000 providers into our network, which is just like if anyone's paneled with Blue Cross or Blue Shield. But with Medicaid, it's always probably 3 times harder. You have to submit a lot of information, be credentialed, have criminal background checks, the whole 9 yards. So we had to do that for roughly 2,000 people. So that was a big focus. During our first year, it took all of our kind of people, skill, sanity to try to get all that information, get it correct, and make sure individuals weren't losing services in the meantime. We've kind of evolved from that now that really more of what we do is focus on quality. and looking at kind of service needs and gaps. So a couple things that we consider now is the Medicaid waiver has access standards for care. For instance, we have to make sure there's outpatient providers available and no more than 30-minute drive, 30 miles from where somebody lives. We have to make sure there's sufficient care that at any given time, 60% of our network are able to take on new referrals into care. There's actually standards that say when someone goes to an office, if they have to wait for their appointment for more than 2 hours, that's a problem and a sign that we don't have adequate network capacity. And then we have to be able to get individuals into care when they seek services either from us or if they call a provider directly within 48 hours if it's considered urgent. So someone with substance abuse needs, someone whose condition is maybe worsening, and then they have to be seen within 14 days for routine care. What's nice about this is because we collect a lot of data, we're able to meet these standards, but also we're able to improve. So in the Alliance area, if you need a routine behavioral health service, it's roughly 4 to 5 days to get into care, which is substantially better than what it was prior to our managed care implementation. The other thing we're able to do is spend more time focusing on quality and implementing evidence-based practices. So we're able to look at kind of segments of our population, individuals who don't really seem to be doing as well. And we see this in our data a lot, individuals who jump around from levels of care, stay in care for short amounts of time, and then meet with our providers to incentivize better practice, either help support them in getting new training. In some cases, the services we provide were not supported at the rates offered by Medicaid, and we're able to use our leverage as a managed care agency to adjust rates. All right, so here's a brief view at our network as it stands today. Obviously, we've had some change and we've had some drop out of the network over time. We had a number of clinicians who joined our network because I had one consumer who was receiving Medicaid funded services. They joined our network to make sure they saw that care through and then leave. But right now, kind of the biggest segment of our population are licensed professionals. And these are people who are independently licensed, and then some work on their own, and some, was it up to 423, are part of a group practice. We have hospitals, PRTFs, and agencies is anything from group homes, agencies that provide assertive community treatment team, residential services. So that kind of falls under an agency bucket. Alliance is now operating a closed network, which means we only take providers in when we determine there's a need in the community. We've left our network open to prescribers. That's always an issue in behavioral health, having people who are willing to treat our population and follow, for medication. Again, so I shared before, the initial focus was on just getting people into the network. Some other examples of what an MCO can do to help support practice in the community beyond rates and beyond kind of just looking at the need is things like learning collaboratives. So Alliance currently has 4 learning collaboratives that we're sponsoring. We bring in an outside expert and we pull together our providers of a particular service line. So probably, in my opinion, one of the key services for children in the state is something called intensive in-home services. If you read the newspapers and occasionally hear that's also a service that's been fairly abused. It's provided in the community. It can be provided by a team of individuals, and the credentialing on a team is mixed. So you have a licensed practitioner who's overseeing the team, but then really the services could be delivered by qualified professionals and associate level professionals as well. So that is probably for children in the Alliance area one of the most highest utilized services. At any given time, we have about 700 or more children receiving that service. At one time, it was up to 1,600 children. It just was not being utilized effectively. So I think we started doing a better job at targeting who needs to be in the service, but we still were having quality issues. So we brought in a consultant. They now meet with our providers monthly. They provide case consultation. They do review. They educate in best practice models. And now we've totally changed our system that in order to provide the service moving forward, you have to identify an evidence-based practice and be able to show us through an external fidelity review that you're meeting. So we're in the process of that transformation. and we think that will greatly increase the quality. We can only do this with the ability to be flexible with rates, provide monitoring and technical assistance. And I'd like to think that's a little bit more than a traditional managed care approach to just cutting the service because it tends to be high cost. So we also have this for our community support teams, which is kind of an intensive short-term service for adults, and for our SAIOP providers, which is substance abuse intensive outpatient, to bring in better practice, including getting more medication-assisted treatment within that intervention. And we also have a collaborative around supportive employment that we think obviously a big part to helping people move off Medicaid to some degree will be able to get employment skills, find jobs, and be supported. So one of the big focuses for Alliance, I think the MCOs, is this idea and notion of integrated care, and how do we do that when we are really unresponsible and paid for behavioral health services. So, one of the concerns we have obviously is even today with all the improvements of healthcare, spending on general healthcare, the population we tend to be responsible for continue to die much younger than their other cohorts. And what's interesting is supposedly 60% of these due to preventable medical conditions, mostly cardiovascular disease. So our approach to this is that we're not the healthcare provider, but we're trying to figure out how to make conditions within our network more favorable for integration. So we've done a couple things. One thing we've done is we've actually started looking at physical healthcare practices, looking at the number of patients they serve who have a behavioral health diagnosis, but have never sought treatment through the behavioral health system. So typically, most children, when they start out getting behavioral health services, are seen by their pediatrician. When you start thinking about the adult population, the majority of adults with things like depression, anxiety disorder, are actually treated in primary care. So to some degree, from an insurance perspective, there's a healthcare savings for us if we can improve the care that goes on in a primary care clinic, keep people out of specialty behavioral health care, but making sure their needs get addressed so we don't get them later once their condition has really worsened. So for us, financially, it makes sense to begin supporting some of our behavioral health care providers by embedding behavioral health specialists who can provide consultation and link to community services if needed. So one of the issues when we talked to primary care is that, they have to see lots and lots and lots of patients every day. And a lot of times they don't do adequate screening because they're afraid once they determine these issues, they're not going to have the manpower to address it. So really one of the goals for our integration practices is to really help primary care bring in, routine screening tools, develop kind of decision trees, and then us provide staffing support by basically paying them additional funding to hire care coordinators in primary care who can help provide consultation to physicians and also navigate into community services if needed. So we have a bunch of pilots right now testing to see if this works. What's nice is one of our pilots is with a large residency training clinic. So we're hoping that this model, which has been relatively well tested other places, has some impact. But again, it's one of the nice things about the flexibility we have as an MCO and how we use some of our savings and funds. So access to care. One of the things that Mary said that people would be interested in is hearing how do people get services in the managed care world. So probably the easiest way is if anyone calls, we have an 800 number, which, shame on me, I don't have memorized, but if you call our 800 number, the phone is answered within 7 seconds by what we call an access specialist. An access specialist is a bachelor's level person, could be a master's non-licensed person, who asks a series of scripted questions, and they ask some standard safety questions. And from there, they can either refer directly to one of our providers, or based on answers to some safety questions, it's elevated to a licensed clinician. So we always have these two type of individual working in our call center. Our call center employs about 27 of these staff to handle these calls. The majority of our larger providers have electronic screening portals with us. So if you're a large provider, you have a shared calendar system with Alliance. The consumer calls, we enter some information on a computer, plug it into this portal. It shows up on a provider's calendar, person has an appointment, and all the information about why the person called seeking services is available. Typically, what we're referring to when you call an access center is just an initial assessment. So we're just doing a brief screening for safety, making determinations about the level of care somebody needs to keep them safe, look at that urgency criteria, and refer to an assessment primarily. We do some crisis work, and I'll talk about that. And from there, provider does hopefully a comprehensive assessment and begins to formulate a treatment plan. So to some degree, that may be the only interaction the consumer has with Alliance as their kind of managed care entity. And it could be for the provider as well. Our assessment services don't require any kind of prior authorization. So if someone presents, they get seen, there's no kind of administrative barrier. Additionally, if you're going to provide outpatient basic services to an individual, we basically don't manage physician services, and we allow something like 26 sessions for outpatient counseling before someone would need to really interact with us. So, and again, it's interesting. What's surprising me, we get about 5,000 calls, sometimes up to 8,000 calls a month, but in general, only about 1,000 of those are actually people calling to access service. The rest is calling for kind of general information. So the good thing is we've done a lot of community education where we want, if someone shows up to an emergency department, if they show up to a crisis facility, if the police interact with somebody on the streets, we want them to call us to figure out if the person has services, if they have a provider, so we can actually get that provider engaged. So it's a big function that we'll do, is make sure we're kind of helping coordinate care when individuals call. And then just lots of general routine questions about benefits coming to the call center. The screening process takes about 8 minutes on an average case. So someone calls, they're asked these safety questions, a couple of questions about preferences. We basically will then provide information about a couple of providers in our network. Usually people choose by geography and referrals made. So the other thing we do is we field a fair amount of crisis calls. So we'll get calls from individuals who are truly in a behavioral health crisis. They right away are escalated to a licensed clinician, and then we implement a number of crisis protocols. One may be mobilizing a mobile crisis team, which can go out to the community, provide support and services to an individual. They can actually stay with an individual for up to 8 hours uninterrupted to help work through a crisis. And then if the person hasn't stabilized, get them to a crisis facility. Sometimes we're having to mobilize EMS or especially trained police officers. So we do those things. We remain on the phone with our consumers until they call. So there's a backside to this. So after someone's had crisis service, the crisis facilities tend to call us, and we go ahead then and link individuals into services. And if they have certain risk profiles, then we'll also assign to them a care coordinator who is responsible to make sure that they actually get to the needed services, next level of care. And they also help craft an initial plan. So in our system, we've tried to set up that there's no wrong door. So if someone calls us, they can access services. If someone calls any of the providers in our network, they can access services as well. So we have a website, a provider directory. So really all it takes is an individual to walk in or call. We've tried to set up an array of services in our community where you can either call, get scheduled time, or in each community, you can just seek services on the day you want them. So a consumer can call one of our larger providers and say, I'd like to be seen, and typically they can be seen the same day. And in some cases, we've set up providers who also provide same-day prescribing services. Those sessions take a little longer, but in essence, in Wake County, insured or uninsured, you could walk into one of our, we call them open access clinics, be triaged by typically a nurse, assessed by a licensed social worker or psychologist counselor, and then see a prescriber all before you go and start treatment on the day you're receiving services. And again, I think that's been one of the nice improvements in our system. Our providers refer a lot to each other. So again, as I mentioned earlier, that typically the first appointment's for an assessment. Often from there, the assessing provider will have to help navigate the person to another provider for more intensive services. And then again, we also operate 24/7 crisis and evaluation centers. So even without calling, someone could just present themselves to one of these evaluation centers and be assessed, screened, and referred to services, including psychiatric inpatient crisis services as well. So in most of our communities, in addition to seeking emergency services in an emergency department, we have these 24/7 kind of behavioral health urgent care centers with facility crisis beds attached. Facility crisis is kind of like an inpatient unit, but the individuals have to be a little bit less acute, and they can't really give forced medications. But other the treatment that takes place in those units. So one of the things that really changed how we operate is really becoming much more data driven. Again, we collect lots and lots of data from different quality surveys. 5,000 phone calls or so a day. We process, or I'm sorry, a month. We process about 6,000 authorization requests. 100,000, claims a month. That gives us lots of information about our consumers. So one of the things that all departments. Thanks. Hello. All right. So one of the things that each of our departments have dashboards with key performance measures. So in our utilization management department, there's a standard that says when a provider submits a request for us, if it's a urgent request, we have to respond to it within 72 hours. If it's a routine request, within 14 days, 10 business days, we have to give some kind of response, because the goal is that we're not allowed to set up kind of any administrative barriers that would keep an individual from accessing care. So those would be measures. Then we look at certain services that we know have been overutilized in the past or potentially underutilized, because we look at both. A lot of times when you think of managed care, you think of just kind of saving money and ratcheting down, but there's certain services we want to see more of. We definitely want to see more assessment. We'd like to see more psychological testing of our consumers, more specialized consultation type services. So more family therapy, more group therapy. So we kind of set different thresholds we want to see, and people, they review their dashboards against that. The other thing is, because we're responsible for network adequacy, and we know there's kind of some limits to the type of services in the community, we look at daily census. So we kind of, at any point of all the facilities we contract with for inpatient services, for psychiatric residential treatment, residential services for kids, we track on a daily basis how many kids are in those services and adults. Here's what's a little frustrating about kind of some of our operations. So one of the things we're responsible to make sure people can have adequate access to care. So we do all these kind of things. We monitor data. Our network department does an annual gaps and needs assessment. And one of the things in our area, and I'm not sure if it's just to Raleigh, Durham, but it may be across the state, there's a perceived shortage of adult psychiatric beds. So we've determined that there's not enough psychiatric beds, inpatient beds in our community for adults. And there's not beds that can accept adults with Medicaid. So here's where our challenge lies, that in North Carolina, there's probably nationwide, there's something called the IMD rule, where basically Medicaid won't pay for services for individuals who are in institutional setting. So freestanding hospitals like in Raleigh, like Holly Hill and Strategic, they cannot accept adult Medicaid. So in our community, we have UNC opened a crisis campus in Wake County. They have 16 beds. So we have 16 Medicaid beds to serve all of our Wake County residents. And for us to expand, we'd have to get either Wake Med, Rex, or Duke Raleigh to develop inpatient psychiatric beds. So some of these things that seem like they'd be simple, we don't have enough outpatient, inpatient beds. We might have some money in the bank, let's build some more. There's always those kind of additional hangups. So we kind of look more to develop crisis facilities. And that's one of the things, there was a question what we're doing with our fund balance. So Alliance has been around for only 2 years. And when we came to the table, we were all county-run agencies. As single county programs, we were not allowed to have a fund balance. Any money we didn't put in services would typically go back to the county because they were putting in money as well. So we came to the table broke. We actually had to borrow from each of our counties about $4 million just to have starting operating capital. Over the course of 2 years, we were able to get some Medicaid savings. And so part of our reinvestment plan is to increase facility-based crisis beds. We're funding an NC START team for children that will provide a community response for individuals with intellectual developmental disabilities. and beginning to enhance the rates of some of our services, which have been underutilized and less effective than we would like. All right, so I'm not going to go through all these, but on any given day, you have staff that are running all these reports, looking at things. We look at our high cost report because, again, there's kind of in managed care, there's good high cost and there's bad high cost. Good high cost is an individual who might be on an ACT team, but they've been in an ACT team, they've been successful, they're not going in and out of the hospital. Their care may cost us $20,000, $30,000 a year, but that's fine. It's stable for that population. It's not a bad thing. We may have an individual has the exact same diagnostic profile whose cost is roughly the same, a little bit higher, or maybe lower, but just consists of inpatient and ED claims. So those are people we say we're not managing effectively and put some interventions in place. Again, talked a little bit about over and under. Trying to do a little bit more around predictive analytics. So one of the things I think private managed care has done much better is they're much better at looking at the overall population and figuring out who's kind of next to be their high cost consumers. For us, that's a little bit new of an art. So we've been developing some predictive models. Some things, it's not rocket science. It just takes a lot of time to review. People who don't fill their prescriptions, lo and behold, tend to escalate up the chain. But there's other predictors we're learning too. There's certain combinations of medicines, benzos and opioids, or children who are prescribed for whatever reason, the magic number of 2 or more medicines for ADHD that are different over a 60-day period tend to have a higher rate of ED utilization. So one of the things we've kind of done is bought software that helps run kind of clinical algorithms. It looks at kind of risk profiles. And then we have people who are reviewing that and can begin to intervene through either outreach to our providers or maybe new referrals for our consumers. The other thing we always look at are key cost drivers. So one of the things about Medicaid is people tend to think about Medicaid as one insurance program, but there's actually different categories of Medicaid. So there's kids who are on Medicaid because they're in foster care. There's people on because they're aged. There's people on because they're disabled. You would anticipate your costs for your disabled population should be higher than people who are on Medicaid, maybe because of poverty or because they have dependent children. So one of the things we look at is by each service line, kind of what's the category or the category of aid it's called that's driving service utilization to make sure it's appropriate. One of the things that's been interesting to us as we look at children who use residential services, it shouldn't be surprising, but about 50% of those kids are on Medicaid because they're in foster care. Then we wanted to look at are those kids that we can potentially begin to help move? Are there different populations within the users of our foster care system we could impact? And what was interesting is we found there was no correlation between kids in foster care, kids in DSS custody who are getting therapeutic foster care, and kids who just enter the treatment foster care system from their parents' custody. So it's always been kind of an assumption that if you're in DSS custody, you're in for much longer, but that's not what our data showed, which should be able to impact, how we move. So the other things we're starting to look at, comparative analytics. Not all of our providers are created equal, and some have much better success with certain populations. One of the things we can do is we have to provide choice, but we can also provide information, educate families about providers that maybe have an expertise and specialty in a certain area. And that's kind of one of the functions of both our care managers and care coordinators. We believe a big reason for one of the decreases in length of stay in our psychiatric treatment facilities for kids was really looking at kind of profiles of children, what does the provider offer, and looking at kind of the outcomes and being able to really be much more directive. Another thing we're kind of looking at is, and you hear a lot about this, is population health. So you're not just kind of looking at kind of the people who are popping up, but you're looking at the whole Medicaid list of numbers we serve, kind of what's the health of that whole group in general? Are there certain populations within all of our Medicaid population that have some similarities? And can we design programs and interventions that would become more beneficial? So some of it may be doing some individualized treatment for groups, but also looking at some different preventive and education strategies to address various populations. And then because we are a health plan, there's certain HEDIS measures we have to follow. So these are certain standardized measures about, things like in behavioral health, what's your 30-day readmission rate? Are you effectively addressing that? Are consumers getting seen within 7 days after discharge? Those kind of health measures. All right. So One of the other functions, won't spend too much time on this, is utilization management. I think this is a big, again, differentiator between private managed care, traditional commercial managed care, not for Medicaid, and Medicaid managed care. You know, one of the things we have to do is make a medical necessity determination. So the state has set criteria. So there's these things called clinical coverage policies. They provide service definitions, and basically providers submit requests to us, and we judge if the person really meets that level of care or not, and approve or deny the service. So that's only half the battle. So, you know, 85% of the time, we just approve it as it's been requested. Another 5% of the time, we kind of say, you know what, we're not really sure. We don't want to deny somebody services. We're going to approve a shorter time frame, less units, go back and develop a better plan, and then we'll take another look at it. And sometimes we deny it. The issue is when we deny services, though, that means the person needs something. So it's very rare that we get a request for a service and just deny it because the person has no problems and there's really no reason for seeking services. So what we have to do then with every time we deny a service, we have to write recommendations, and then we're actually responsible to see if those recommendations are being followed. So if we deny a residential level of care for a young person, we have to make sure they're getting some level of appropriate follow-up. And I can tell you, based on the numbers, that doesn't happen with the regularity we would like, but with our highest cost consumers and our highest risk consumers, that is standard practice. If we have someone in a psychiatric hospital, we're not going to deny their care unless we know the next level of care is available. So it's more than just reviewing against a set standard of criteria. It's really looking at what this individual is going to need over the long term. And a big function to us is making sure people are in the least restrictive settings as possible, and kind of focusing on two populations. We want to focus on outliers. Are there individuals who, for some reason, their consumption of healthcare is significantly different than the rest of the population, and understanding what those drivers are, help develop plans. But there's also a big focus on moderates, and this is something that's really interesting that really most health plans do really poorly. If you look at your kind of best health plans, they have great programs for high utilizers. They give people cell phones, health coaches, you know, all kinds of remote monitoring. So we do a good job, and that's in the private sector. We're not that fancy yet, but dealing with our highest risk folks, we give them a care coordinator who follows their care for a certain period of time, and that's kind of what we can do in our more expensive services. But there's this whole group of individuals who really someday will be your high-cost consumers, and if we can do a better job focusing on what that population looks like, making sure they're getting adequate services while they're still at a moderate level, over time, the assumption is you're going to start shrinking down your outlier population. So we actually spend a lot of time focusing on this. One of the things we routinely look at is we assume most people with kind of moderate issues will access outpatient therapy and medication management. So we do a lot of surveillance on our data to see what's the mean number of sessions people are using and trying to learn what's a barrier. It's really unfortunate. Our first year, we went back, and the mathematical average showed that the average person who got an outpatient service kept 2 appointments, and that was it. So you can imagine if you felt bad enough to seek behavioral health services, kind of go out your comfort zone, call somebody, walk into an appointment, and then only show up really 1 or 2 more times, you can imagine that issue is going to recur. So our goal is to figure out how to make that system friendlier and find out, is there something in the network that's keeping people from using services the way you should. And we've gradually seen some improvement with dealing with some providers around practice improvement, and then looking at our processes as how we match individuals as well. So it's a big focus for us in managed care. So I can have about 1 more minute left, and I'll just take some questions. One of the things we do is care coordination, and care coordination was never intended to replace case management. I'm not sure what was intended to replace case management, but that really wasn't the goal of care coordination. Really, for us, care coordination means that we should be ensuring that people have some special needs, are linked, being followed, have good treatment plans the best as possible. We should be working with providers to make sure certain things are addressed. A big thing for care coordination is looking at the various social determinants of health. Are people housed? Do they have access to health care, food, transportation, child care, things that could be barriers? The problem is we don't have the manpower and not funded such to do that legwork. It really is about getting individuals linked to a provider and the provider agency doing most of those things. So then our job becomes making sure that we're referring to providers who have case management in the system. So this is a good and bad thing. One of the services it does is this child intensive in-home service. It provides good therapy activities. It provides some case management, but it's typically episodic. So a child might get that for 3 months, maybe 6 months. They may have those ongoing case management needs, which then can't be addressed by service. They're not in the population group that the state tells us we have to focus on, because it's in our contract saying if someone meets a certain condition, if they've been hospitalized, if they're at a certain score in a standardized assessment, we must provide care coordination. But then there's other populations we can, if we have capacity. So there is still this group who kind of gets linked to service, begins doing okay in services. We step out of the system. And then when they're kind of graduate out of their service, they sometimes are left without another resource. And I think that's just an ongoing challenge that we're going to have to address. For some of our populations, that's not the case. So someone who's on that innovations waiver, the C waiver, that's kind of an entitlement service. You get care coordination and follow-up for the life that you're on that waiver. One of the things we've done with care coordination is we know there's certain kind of risky parts for individuals in our system. Individuals coming out of emergency departments, hospitals, and psychiatric residential treatment facilities. So we actually embed our staff in those areas. So they're not actually doing, again, a case management function that they're doing tons of following, but they're making sure when someone shows up they're being well coordinated and hopefully being handed off appropriately from those settings. And again, I think it's been really successful as far as diverting individuals who show up at the emergency room back into the community with some supports. And we think that's been helpful in helping to cut down our readmission rate to inpatient facilities as well. So, and the last section of what we do is we have, again, community relations. So that's the arm of the MCO that really works on system development relationship. We do training for police, help develop programs that are paid for, not through Medicaid, making sure schools, DSS, DJJ, housing guardian programs are able to access services and get support. So a lot of their role is that kind of community and relationship building. So that's kind of a high-level overview of the work we do. With a couple minutes left, if there are any questions, I'd be happy to try to answer them. Thank you.